So I have no disclosures. Forward slide, sorry. So this patient's 66 years old. He's got severe degenerative mitral regurgitation. He has a flail P3 scallop, presenting with New York Heart Association class 3-4 symptoms. So he had a median sternotomy at age 17, presumed to have an ASD, and once they did the sternotomy, they found that he didn't really have an atrial septal defect, so they didn't do much of anything for him. He also has a congenital conduction system defect, for which he's had multiple pacemaker implants, lead and battery revisions, and more recently, 3 years ago, he got an ICD implanted. And just given that his comorbid conditions, his frail and inoperable state, they thought that maybe he's better suited for mitral clip procedure. So in terms of his medical and surgical history, he has non-ischemic cardiomyopathy, EF of 35 to 40%. He's had both pacemakers implanted in both pectoral sites and even lower abdominal sites. He has both external and internal leads. By the ICD, he has stage 3 CKD, history of alcohol use. So his STS mortality risk was 21%, and his morbidity mortality was 61%, and that's why in a 66-year-old we decided to go down the road of doing mitral clip. So echo, again, moderate tricuspid regurgitation, EF of 35 to 40. He has a P3 scallop that's prolapsing, and he's got a very severe eccentric mitral regurgitation, anteriorly directed jet. And on Cath, he didn't have any significant disease. His PA pressure, mean PA pressure was 32, wedge was high, but since then, from that time to the time of his procedure, he had been diuresed pretty well. So this is the echo on the day of the procedure. This is your deep gastric view, where you can see your aortic valve there, your alveolar flow tract. Here's your mitral, and you see how eccentric that MR jet is and how it's hugging the whole anterior wall. Here's a 4-chamber view just to kind of show you guys that his left atrial size is big. The intraatrial septum looked like a nice thin septum. His EF is down. His RV is also slightly dilated with mildly reduced function. And he had moderate tricuspid regurgitation, more related to lead impingement from all the leads that he had. So just kind of looking through the anatomy, I know that it's hard to, on these 2D images, to appreciate that prolapse or that flail of the P3 scallop. But as you can see, as we go from the 4-chamber view to the bicommissure view, you start to appreciate that eccentric jet coming in. This gentleman, unfortunately, had a TE initially done at a different hospital, and if you go and examine him, you put a stethoscope on him, you can hear a very loud murmur. But when you looked at the TE images, you really couldn't show that MR jet. So just to prove to my surgeons that there is indeed severe MR, to repeat his TE and make sure that we capture the jet so they see that there's definitely an eccentricity to it. Here's 3D view. This is a surgical view with the aortic valve at the top, and here's your P3 scallop that's prolapsing up into the atria. So I put this slide in just to, when you have a very eccentric jet, I don't know how reliable the MR radius is and velocity, or the ERO calculations that we come up with, but we've kind of just based on his exam, his symptoms, and looking at the color Doppler itself, we were convinced that he had severe MR. His mean gradient across the valve was 2 to begin with. His PA pressures on echo kind of correlated with what we found on Cath. So on the procedure day, again, we just started with the deep gastric. One more time, just kind of showing the MR jet. That's our clip going in. There's nothing exciting about the clip case itself, so we got a good capture of both the posterior and anterior leaflet, both A3 and P3, and we tightened up the clip and saw a reduction in the MR, and we were happy with our location and how much reduction of MR we got, so we released the clip. This is just a mirror image, so you can see the clip that's right in the P3, A3 area. So this is immediately after, so we always pay attention to the blood pressure before and after, so it wasn't a reduction in blood pressure that caused the MR to look better. So his pressures were 120s, 130s before and after, so you can see an improvement in his, a significant reduction in his MR. His MR came down from 3 to 4 plus down to 1 plus. So in his mean gradient across the valve didn't really go up much. It was 2 to begin with, and after the clip, it was 3 millimeters of mercury. So, we took the device out, we took the transseptal sheath out, and we did just a final sweep to look through this, and we looked at our intra-atrial septum and noted that it looked like that atrial septum was torn more than what we normally see. There was a large left to right shunt, and they calculated the QPQS on echo itself, and it came out to be around 2. And we were debating whether to just leave it or not, but in this gentleman, just given that he has this big shunt and he's got RV dilation and a little bit of RV dysfunction to begin with, we definitely didn't want him to leave him with more volume overload later leading to RV failure, so we decided to close it. So I don't know how well you can see. You can see that there's a lateral tear in that intra-atrial septum. So looking at the 3D images, we initially thought that maybe it was too big of a tear for Cardioform, and probably Amplatzer Septal Occluder would be better. So we decided to get both 3D measurements, 2D measurements, and then we also erred on the safe side and did a balloon sizing. Took a 24 millimeter Amplatzer sizing balloon, inflated it until there was no more color flow across the defect. The largest size that we measured was about 14 to 15 millimeters, so we decided to go with a Gore 30 millimeter Cardioform Septal Occluder. We're still attached at this point, just made sure that we had a good grasp of all of the rims and looked to make sure that there wasn't any color flow across it. We were happy with it. We deployed the atrial septal occluder, and then that's on the echo before where we had done a bubble study just to show you that he didn't really have any defects to begin with, so this is all truly iatrogenic. And then after we had released the septal occluder, we did a bubble study, and there's really no shunting across. I just put this image in just to show you the number of leads that he's had, what his anatomy looked like under fluoroscopy. So like I said, it's not really one of those, we saved him from death or anything, but just pointing out that many of the interventional and EP procedures that require transseptal puncture can lead to a persistent iatrogenic atrial septal defect, and majority of them tend to close. And I think Dr. Robert Schuler and his team looked at 66 cases of mitral clip patients and followed them for 6 months, and what they noted in their study, about 50% of them still had a persistent iatrogenic atrial septal defect. There's not a lot of clinical outcome, there's not a lot of data out there to say, should we close all of this, should we not close all of it? It's still kind of unclear. I think in these mitral patients, at least, it's bigger sheets that we're using. A lot of them, especially when you get to treating a lot more of the functional MR, they come with a lot of cardiomyopathy, both right-sided and left-sided failure. So maybe this is something that we should give a little bit more attention to just not wait and see how they do in the follow-up, but should we just, since we're already there, the patient's under sedation, we have access, should we just go ahead and do a good assessment there and decide to close if they do have some component of RV failure or a large enough shunt? So when to close it, I think just about everyone will agree that if there's refractory hypoxemia during the procedure, most people will close the defect. If there's a large atrial septal, if there's a large shunt with the QPQS greater than 2 and there's concern for RV overload, then you can go ahead and close it. And also another reason for him that we decided to close it is because he's got leads in there, so we were concerned about if that stayed open, about paradoxical emboli in him. So these iatrogenic septal defects tend to have irregular borders and edge tears, so make sure that you do a good 3D sizing and also balloon sizing before you close it. If your left atrial pressures are high or your wedge pressures are high, that's probably a time for you to just take a pause and not close it. Or you could occlude the balloon with a balloon and then see how the patient does, and if their LA pressure is going up, then don't deploy the device and then reassess at a later time. All right, thank you.